Hello, I'm here to tell you about the Primary Trauma Care Foundation and the Primary Trauma Care course. My name's Nigel Rossiter. I'm a trauma and orthopedic surgeon from the United Kingdom. I have been the chair of the Primary Trauma Care Foundation and the medical director. I've now handed those roles over, but I remain on the board of trustees. And if you're really bored, you can read a bit about me on the website on that picture. Now, first of all, we need to define what I'm going to talk about. And I'm talking about physical injury. Trauma to anyone in the medical world means physical injury. It does not mean mental ill health. So I'm going to be talking about physical injury. Trauma or injury is what I call the forgotten pandemic. There are more people who die every year from injuries than all contagious disease added together. That's HIV, TB, malaria, mumps, measles, and COVID-19. That's 5 to 6 million people a year. But we focus on the deaths, but there are many more who are injured. 40 million become permanently disabled and 150 million temporarily disabled every year. And that has a massive effect on global GDP. In high-income countries, that may be 2 or 3%, but it can be 10 times that in a low-income country. Now, the problem is we tend to zone out when we're looking at figures of that size. So let's put this into perspective. We're talking about the death of the entire population of the island of Ireland every year, year on year. And we're talking about the entire population of Central and Northern South America being injured every year, year on year. Injury or trauma is the leading cause of death in the 5 to 30 age group. And why is that a problem? Well, because the vast majority of the world lives in a country who are under the age of 35. So you're affecting the working population. And as I said, we focus on the deaths, but there are 97 people not working for every death that occurs. And the outcomes of injury are very different depending where you are in the world. If you're in a high-income country and you break your leg and it is a closed fracture of your tibia, your lower leg, where the bone does not come through the skin, you would be pretty upset not to get back to work in 6 weeks. And I, as a surgeon in the United Kingdom, would be upset. But that is not true in a low-income country or a low-resource environment. Beautiful study done by the Vancouver group with Makerere University from Kampala in Uganda, looking at the outcomes of a simple closed tibial fracture in a working age man. And it took them an average of 18 months to get back to work. Within 6 months, their children were out of school to earn money to keep the family fed. And because of the extended family network, the extended family was destitute within 12 months. Now, prior to COVID, the numbers affected by injury dwarfed those in terms of deaths every year of contagious disease. But contagious disease got 36% of global healthcare funding and injury just 1%. Since COVID, the funding for contagious disease has gone up to over 60% of global healthcare funding, and trauma gets proportionately less. Now, I've got pretty upset about that, as have a number of others, and I've written about this, as have a number of others, and the World Health Organization are doing something about that. And at last year's World Health Assembly, trauma was back on the agenda. Now, we know that most trauma, most injury happens where most people live, and these bubbles represent where the global population is today. But those bubbles are changing, and the yellow and the green are going to shrink relatively soon. The red are already shrinking in China and will increase in the Indian subcontinent, but will decrease. But the ones that are really going to change are the blue bubbles in Africa, particularly sub-Saharan and West Africa. We know that training people to look after injury is incredibly cost effective. It's 135 times more cost effective to do it than to give antiretrovirals for HIV. I'm not saying that that's wrong, but it is much more cost effective and will affect many more people in the world who are affected by the world's biggest healthcare issue by training people to do it. And if we do it well, the World Health Organization has shown that we can prevent half of all deaths and a third of all disabilities in low resource areas by training people properly. Now, in high resource areas of the world, the Advanced Trauma Life Support ATLS system of care and communication has been revolutionary, and it is now the gold standard accepted level of care in all high resource areas of the world. The problem is that it is relatively expensive. It costs £1,000 a go for people to attend the course, and it's relatively didactic, teaching people to attain standards of care that we'd expect in a high resource area. And the vast majority of the world does not have that access to really good healthcare. So that's where we come in. The primary trauma care course is effectively ATLS for low resource areas. We're recognized by all of these organizations, and we are probably the largest organization in the world that no one has ever heard of, training people globally to do good initial injury care. And what's the big difference? We're free. We do not charge people to attend our courses, and we make sure that we train local faculty so that it is cascaded and autonomous locally. That way, it's very cost effective and people have ownership of their own training. So how do we do it? Well, traditionally, we do what we call a 2-on-2 5-day training sandwich. So on the first 2 days of a course, say on a Monday or a Tuesday, we'll have about 20 to 24 people come in to be trained. And we'll have an initiating faculty doing that training those people. And during those first 2 days, 10 or 12 of those people are selected to become instructors. And they attend a training the trainers course on the third day to learn how to teach PTC. On day 4 and day 5, those people then become the instructors for another 20 to 24 new people who come in, and the initiating faculty sit in the background to ensure quality control and to answer any questions that the new faculty can't do. So by the end of that 5 days, we've got 40 to 48 newly trained people with 10 to 12 new instructors, so that the course can be cascaded out in whatever country it is gone into, and people become autonomous and take control of it. Now, we know that it's very difficult for people to attend 2, 3, or 5 days away from work. That is certainly true in high resource areas. It's much, much more difficult in low resource areas of the world, taking healthcare workers away from work for that long. And so the course is also modular. There are 10 modules that can be done in 1 to 2 hour sessions. So you could have a session every Tuesday afternoon for a couple of hours, do the training, and within 10 weeks, you are fully trained. All of the materials are freely downloadable from the website in many languages. And in the last few years, since COVID, as we know, IT has come on enormously, and we have been working with the Intuitive Foundation in America to make this course freely available on the Apropedia platform, which is the platform that Wikipedia is based off, so that it is available in almost any language and in a format that everyone recognizes. So you can just Google PTC Apropedia and access everything for free. Since 1996, we're now in 87 countries and have trained probably about 1 million healthcare workers. And as we're so widely spread around the world, we have a large team of coordinators around the globe who report to the Board of Trustees, who are at the bottom of this picture, and we report to our boss, Sir Terence English. Now, we're not just involved in training people to look after people who are injured. We're massively involved in advocacy. So we have done a lot in recent years, working on trying to prevent people getting injured in the first place. And images like this, unfortunately, are very all too common in low resource areas of the world. And there's lots we can do about that. We know that the care that people receive when they first get injured and come into hospital is extremely variable. And we're working to try and level that up. And we may be really good at saving people in the emergency department or the operating theatre, only for them to go to a ward where the care is extremely variable, infection control may not be terribly good, where they languish and or suffer because of post-operative, post-injury infections. And the one thing that no country in the world has sorted is rehabilitation, getting people who are injured back to being functioning members of society and contributing to their GDP of their country rather than being a drain on it. Now, in England, we recognised this some time ago. And the first 10 years of my consultant career were involved in trying to get a trauma ecosystem up and running in the UK, which we achieved in 2010 and 2012. And it has made a big difference. So in 7 years of instituting that, your chance of surviving major injury in England is 20% higher than it was in 2010 and 11, and it costs the country less money. And we go on improving. The problem is that is not replicated globally. And we can do something about this. We need to do something about the single largest unaddressed global healthcare issue. Now, we have what our new chairman, Steve Jackson, calls a bag, a big, hairy, audacious goal. We want in the next year to get our mobile training app out there to deploy it globally to allow people to get better access to the training. We'd like by 2030 to have trained another 1 million people, to have another 50 low and middle income country governments having come on board with memorandums of understanding, and help the World Health Organization to adopt a universal trauma care network. By 2035, all of us would like to achieve a 50% reduction in preventable low resource area injury-related deaths. And by 2040, to get those autonomous trauma ecosystems, injury ecosystems in 100 countries around the globe. Now, we've had some events in London to try and help us try and achieve those, and they really fall into 4 categories. We need income to help us do that. So new income streams, we need robust marketing plans, really good governance structure, and to extend our reach and influence. And this is where you come in. We need your help. We really need people's help globally to achieve all of this. One of our founders summed this up very nicely, that we have until recently run on the fumes of an oily rag, and that has to change. We run very lean, and we need to raise funds by getting people to introduce us to their companies, make us the charity of the year, introduce us to your networks to achieve that big, hairy, audacious goal. We're very open to people giving us ideas for training and digital advice, and certainly for administration and marketing support. And if anyone is out there who is interested in really helping us by becoming a trustee with us, particularly if you have legal, accountancy or marketing experience, we're all ears, but we're all ears to anything that may be of use. We need to raise some funds. We have just spent some considerable time and money rebranding ourselves. And we need to raise £30,000 in the next few months to pay for that. To achieve the first bits of that big, hairy, audacious goal, we'd like to raise £150,000 by next year, £500,000 by the following year, and double that the year after, and then go from strength to strength. Now, if you want more information about what we do, there's a couple of short films here, and you can scan those QR codes that will take you to some very short films on YouTube that will give you a little bit of a flavor of what we do, with a short introduction and then actually an on-the-ground video of PTC in action on the ground in Haiti a few years ago. Now, as I just said, we've just rebranded. because people don't understand trauma as being injury, you will see us referred to much more as life and limb. So we are an organization that will be referred to as Life and Limb, delivering the primary trauma care training course run by the Primary Trauma Care Foundation. That QR code will take you to our website, which will change in June of 2026. And I will take you to our fundraising pages or how to get involved. And if you want to contact us, our chairman is Steve Jackson on the left, and he can be contacted on the email at the top. And our medical director is Jay Krishnan, who is based in South Africa, contacted on the email below. Please do contact us if you wish any further information.